Hello, I'm Dr. Robin Miller, and you're watching HealthDay's conference coverage exploring research with the world's leading medical professionals. The American Academy of Neurology held its annual meeting from April 22nd to the 27th in Boston, hosting a cohort of researchers who presented the results of cutting edge science across all specialties in neurology. For more details and highlights from the meeting, I'm pleased to be joined by the American Academy of Neurology Science Committee Chair, Dr. Natalia Rost. Dr. Rost, thank you for your time.
Thank you very much for having me.
So, what was the general theme of the AAN meeting?
It really covers the breadth and the scope and the incredible diversity of neuroscience and neurological research that's available now. So we're excited, and it's my great honor to present the entire science committee of the American Academy of Neurology in that.
So, during the annual meeting, one study presentation showed the prevalence of neurocognitive disorder in pre-Huntington's disease was surprisingly elevated. And the researchers stressed that establishing a clinical diagnosis of neurocognitive disorder prior to motor manifestation is critical for accessing services. What significance do these results have in access to services, longitudinal care, and incorporating neurocognitive disorder criteria into clinical practice?
This was a very interesting study. It was a small case control study that compared patients with pre-Huntington disease, as we define it currently by clinical criteria, versus controls that were closely matched by age and years of education, which, as you know, is very important in comparing cognitive background. Even though it was a small study, it really showed that cognitive signs of cognitive decompensation are much more prevalent in those patients who have pre-Huntington's disease. To me, this is first of all an indicator that we have a potentially new screening test for Huntington's. And for those patients who are known to be at risk for Huntington's disorder, they may need to be included in preclinical investigations earlier. They certainly would benefit from clinical assessment to indicate whether they have a degree of cognitive impairment that is way beyond what the age norms would be, predicting, and also provide potentially access to services and plan for long-term disability.
A study presented at the meeting showed that a significantly higher number of individuals with Alzheimer's disease reached amyloid clearance and amyloid plaque reductions with donanemab versus aducanumab at 6 months. The study provides the first active comparative data on amyloid plaque clearance in patients with early symptomatic Alzheimer's disease. How do you foresee this data changing the Alzheimer's disease treatment landscape?
In my view, this is just the beginning of the road. As you know, in the past several years, monoclonal antibody treatments for amyloid removal have kind of entered the scene of the Alzheimer's disease treatments. It was an exciting era when the entry happened. It was also somewhat controversial, as you know, in a lot of discussions with regard to the potential efficacy, what other follow-up studies and other types of observations are needed to really detect the safety, potential safety implications, as well as the larger impact of those treatments on the field, considering the type of populations that are affected, as well as the type of treatments that may actually be effective in those populations. Now, enters another monoclonal antibody, one of, I'm sure, many more to come. I think this study particularly was exciting because it was a head-to-head comparison between the two. It really did show, based on their data, again, the sample size was somewhat small, 148 patients, but they did show in a one-to-one randomization that the amount of amyloid, beta amyloid removed by the donanemab was greater than that removed by aducanumab. It also caught my attention that the number of adverse events that we closely monitoring right now with this type of amyloid treatments has been reported similar in both groups. But the ones that we worried about the most, they're called ARIA or amyloid related imaging abnormalities on the brain imaging of those patients, they were differing in a number of those populations with almost none noted in dynamic groups. So I think it's encouraging.
And lastly, data presented at the meeting reveal the Black patients with dementia are less likely than white patients to receive each of the 5 classes of medication for dementia. Why do you think this disparity exists? And what can clinicians do to close this gap? And what is the American Academy of Neurology doing to eliminate disparities in treating patients with dementia?
Thank you for highlighting this particular important study. We also noted it in the review of the original abstracts that were submitted to the meeting, obviously, and chose to highlight it specifically for that reason, but also for another conclusion that was very interesting in this particular abstract. If you noted, while there was a significant disparity in prescribing of 5 classes of medication to this particular population compared to, let's say, white patients, we did notice that when the Black patients were referred to specialists, particularly to neurologists, the prescription rate or frequency for those medications actually equalized. So it's important to me to understand when I read that type of an abstract, what is the kind of a first line of defense could be in such a complex and multifaceted issue that we've been dealing now for decades with, but also continue to deal with that, as we grow our understanding of how complex it is. As you know, a lot of the healthcare disparities are rooted in complex societal issues. There's certainly issues of structural and systemic racism that came to life and to shine, I guess, to light in terms of the understanding, even through the lens of pandemic most recently. I can tell you that from the neurological standpoint of view, neurologists are dealing with a lot of health issues that are affected by healthcare disparities, stroke, dementia, epilepsy, and TBI. We know that those populations are exposed to the effects of disparities in a great effect, in a great kind of a measure. And so addressing these disparities, not only at the bedside, but also at the organizational level, has always been a priority for the neurologists and for the American Academy of Neurology. But I would say in the light of the recent years, we actually renewed our commitment to diversity, equity, and inclusion, not only as it relates to patient care, but also as it relates to growing a diverse workforce of neurology professionals. Because as you know, I'm sure you are aware of the fact that, having the diverse and inclusive workforce really facilitates the care environment that is also inclusive and equitable for our diverse patient population. So that's step number one. And so the American Academy of Neurology not only expanded its reach of the program to be inclusive and diverse, not only offered opportunities for leadership training. For example, we have a diversity leadership university program at the Academy, but also expanded our efforts in diversifying the science.
Dr. Rost, thank you for your time today.
Thank you.
You've been watching Health Day's conference coverage. Thank you.